Welcome to the Deep Dive, the show where we take a stack of information, unearth the most crucial insights, and transform them into knowledge you can truly master. Today, we're plunging into an incredible, often unseen battle happening inside our bodies every single second: our immune system.
It really is amazing when you think about it.
It's an absolute marvel of biological engineering, tirelessly protecting us from a constant barrage of threats, from tiny invisible viruses to complex multi-celled bacteria. We're going to dissect its sophisticated strategies, explore what happens when these vital defenses falter, and then delve into the groundbreaking science of how we augment these natural defenses through immunization, especially with vaccines.
It's a huge topic covering a lot of ground.
It is. Our journey today is guided by comprehensive excerpts from a key pediatrics textbook, providing the factual bedrock for our exploration. You're not just going to skim the surface. You'll gain the kind of detailed, nuanced understanding that truly sets informed professionals apart. So let's get started and explore the body's fortresses.
Okay, so when we talk about our body's defense mechanisms, it all kind of boils down to two magnificent pillars, right? Innate and adaptive immunity.
That's right. They work together, definitely in tandem, like a dynamic duo, but their approach, well, it couldn't be more different.
How so? Let's start with innate immunity.
Okay, think of innate immunity as your body's ancient, ever-vigilant guard dogs. It's the primitive immediate response system. It's non-specific. That means it reacts generally to any perceived threat, doesn't matter what it is.
Something's wrong.
Exactly. And crucially, it has no memory. It encounters a threat, deals with it, and then it's like it forgets it ever happened. It's always your very first line of defense, ready to go instantly, constantly patrolling. Right. And then contrasting that, we have adaptive immunity. You called it the special forces.
Yeah, that's a good analogy. This is the highly evolved, sophisticated arm, really built for precision. What sets it apart is its remarkable specificity. It doesn't just react generally. It targets particular microorganisms, like a sniper zeroing in on a unique target.
Okay.
And here's where it gets really interesting. It's a crucial feature of memory. Once it identifies an invader, it retains that critical information.
It learns.
It learns. It's like the body builds a specialized defense plan after each battle, and that allows for a lightning-fast and incredibly powerful response upon re-exposure. It learns, adapts, and evolves with every challenge it faces.
Incredible. To really appreciate this, let's take a deeper dive into the innate system's components, maybe starting with the complement system. Sounds complex.
It does sound complex, but it's fascinating. Imagine this cascade.
Yeah.
Multiple proteins just circulating in your bloodstream, completely inactive, dormant precursors.
Just floating around.
Just floating around, but then something triggers them. And it's like a biological chain reaction, a domino effect, where these proteins sequentially activate each other, and they generate this highly effective defensive force. It's a precisely orchestrated cascade designed to amplify a small signal into a really powerful response.
Okay, so how does it get triggered? You said there are different ways.
Yes, there are three distinct pathways that can kick off this cascade. The first is the classical pathway.
Okay.
This one is most commonly initiated when antibodies, which are part of our adaptive immune system, remember them,
Right.
when they bind to antigens, forming what we call antibody-antigen complexes. So it often acts as a bridge connecting the adaptive and innate systems.
Oh, interesting.
But what's truly fascinating is that it can also be triggered by certain danger signals. Things like polyanions, heparin or protamine, for example, or even nucleic acids released from apoptotic cells, dying cells.
So it's not just waiting for antibodies. It can sense general trouble, too.
Exactly. It can respond to general signs of cellular distress.
So it's not entirely dependent on a pre-existing antibody response. What's the next pathway, then?
That would be the alternative pathway. This one is quite unique. It's always kind of simmering. It's continuously active at low levels due to a spontaneous breakdown or lysis of a key protein called C3.
Always on patrol.
Right. But its activity gets significantly amplified when its components bind directly to the surfaces of pathogens. Think of things like bacterial lipopolysaccharides, endotoxins, or even components of yeast cell walls. This pathway is really good at direct pathogen recognition. It bypasses the need for specific antibodies to sense trouble.
So the alternative pathway is always on patrol, ready to boil over when it detects something inherently not self. And the third one?
The third is the lectin pathway. This one springs into action when a specific protein, called mannose-binding lectin, binds to mannose residues. Yeah, these mannose residues aren't typically found on our own human cells, but they are commonly present on the cell surfaces of various pathogens. So it's another direct way for the innate system to identify invaders without needing prior exposure or antibodies.
Okay, so we have these three distinct ways to kick off the complement system. Three different alarms activating this powerful cascade. What happens next? What are the measurable outcomes? And more importantly, what do they actually do to protect us?
Right, the downstream effects. Well, when the classical pathway is activated, you'll see a measurable reduction in the levels of specific complement proteins like C4, C2, and C3.
You can measure that in the blood.
You can. In contrast, activation of the alternative pathway is characterized by reduced C3, but normal levels of C4 and C2. And these changes aren't just academic, they can be used diagnostically to figure out which pathway is mainly involved in an immune response or maybe a deficiency.
Okay.
But beyond these markers, the real immediate impact, the direct killing power, comes from something called the membrane attack complex, or MC.
A meta-C. That sounds pretty serious.
It is serious for the pathogen. Regardless of whether it's the classical or alternative pathway that starts things off, the activation of C3 eventually leads to the formation of this MASI.
Okay.
Think of it like a microscopic drill.
Okay.
This complex binds to the surface of bacteria, fungi, even some enveloped viruses, and it literally punches holes in their outer membranes.
Wow.
Until they burst. It causes lysis. It's a direct, brutal, and highly effective way to eliminate threats.
That's incredibly direct. But are there other roles? Do these activated complement proteins do other things besides direct killing?
Oh, absolutely. The MAC is just one part. The C3b component, for instance, plays a crucial role in what we call opsonization.
Opsonization.
Yeah, imagine it like tagging immune complexes or foreign cell surfaces with a bright flag. When C3b binds to them, it makes them far more easily recognized and engulfed by phagocytes.
The eating cells.
Exactly. Your body's specialized eating cells. It's like putting a big eat me sign on the invaders, greatly increasing the efficiency of their clearance.
So it helps the cleanup crew.
Got it. What about C3a, C4a, and C5a? They sound different. Signaling, maybe?
You're right. They are signaling molecules. These are known as anaphylotoxins. They bind to specific receptors on mast cells and basophils immune cells packed with inflammatory mediators.
Okay.
This binding triggers a rapid degranulation. Basically, they spill their contents, releasing powerful substances like histamine and various intracellular enzymes. This whole process is a key part of initiating the inflammatory response, which is crucial for bringing more immune cells and resources to the site of infection.
So they're the alarm bells starting the local firefight, essentially. And they also act as chemokines, right? Guiding cells.
Yes, specifically C3a and C5a are potent chemokines. They play a critical role in directing immune cell traffic. They induce monocytes, macrophages, and neutrophils, key innate cells, to adhere to the vascular endothelial cells lining your blood vessels.
Stick to the vessel walls.
Right, which then facilitates their extravasation. That means moving out of the bloodstream and into the inflamed tissue where the infection is.
And once they're out, these chemokines then guide their chemotaxis, which is directed movement towards the very source of infection. It ensures immune cells arrive exactly where they're needed, like a guided missile system.
That's a truly sophisticated system. Direct killing, tagging, calling in reinforcements. It really paints a picture of intricate, coordinated biological warfare. Speaking of reinforcements, what about the cellular components of innate immunity? Who are the actual soldiers on the front line?
Right. Beyond the complement proteins, the main cellular players in innate immunity are polymorphonuclear leukocytes, that includes neutrophils, eosinophils, and basophils, along with macrophages and natural killer, or NK, cells.
Okay.
All of these cells are primarily involved in ingesting extracellular material through phagocytosis. They are the frontline devourers, engulfing and destroying invaders, cleaning up debris, and acting as really rapid responders.
It's clear that innate immunity is complex, multi-layered. But as we said, adaptive immunity takes sophistication to a whole new level, especially with that memory function. How does that system develop, and who are its key players?
The adaptive immune responses develop through this really powerful synergy between specialized immune cells called lymphocytes and what we call antigen-presenting cells, or APCs.
IPCs, right?
The sophisticated interaction happens following a specific antigenic challenge, basically, when the body encounters a particular unique foreign substance. The hallmarks of this system are its tremendous diversity. It can recognize almost anything, and that absolutely critical feature of immunological memory.
The memory again.
Yes, which ensures a faster, stronger, more efficient response the next time it sees that specific threat. The key cellular components here are lymphocytes, macrophages, and those crucial antigen-presenting cells.
So how do we identify and classify these lymphocytes, like in a blood test? How do we tell them apart?
Well, in peripheral blood, lymphocytes usually make up about 20% to 40% of your white blood cells. We classify and identify them using a technique called flow cytometry.
Flow cytometry.
Yeah, it uses lasers to detect specific protein markers on their cell surfaces. These markers are often called CD markers, like unique barcodes. For instance, B cells are identified as CD19 and CD20 positive. T cells are CD3 positive. And natural killer, or NK, cells are identified as CD16 and CD56 positive. Each marker tells us what type of lymphocyte we're looking at and gives us clues about its function.
That's very precise. And among T cells, there are different categories too, right? They don't all do the same thing.
That's absolutely right. The T-cell antigen receptor, or TCR, is a crucial component. It forms a stable complex with CD3, called the TCR-CD3 complex, which stays put even when the cell divides. Now, what's absolutely critical about TCRs is this. They don't just recognize antigens floating freely. They only recognize antigens when those antigens are bound to MHC molecules, major histocompatibility complex molecules on the surface of an antigen-presenting cell.
Ah, so they need that specific presentation, a formal introduction almost.
Exactly. It's a fundamental requirement for T-cell activation, a strict presentation rule.
So T cells need that specific presentation. And then these mature T lymphocytes further specialize, becoming even more targeted.
Yes, they mature into two primary categories based on their membrane glycoproteins, CD4 plus T helper, TH cells, and CD8 plus T cytotoxic, TC cells. In peripheral blood, you typically find a normal CD4 plus to CD8 plus ratio of about 2.1.
2 to 1, okay.
Now, CD4 plus T helper cells are unique because they recognize antigens only if those antigens are bound to class II MHC molecules. On the other hand, CD8 plus T cytotoxic cells recognize antigens bound to class I MHC molecules. This distinction in MHC recognition is really central to their different functions.
And these T helper cells, the CD4 plus ones, are the orchestrators, right? Differentiating into different subsets. How do they specialize and direct the immune response?
They are definitely the orchestrators. Under the influence of various chemical messengers called cytokines, T helper cells differentiate into specialized subsets, each with distinct roles. For instance, Th1 cells are crucial for supporting inflammation. They're vital in activating cytotoxic T cells and macrophages. A classic example of their role is seen in conditions like tuberculous leprosy and rheumatoid arthritis, where a really robust inflammatory response is key.
Okay, so Th1 drives inflammation. What's the counterpoint? The subset focused on antibodies.
That would be the Th2 cells. They are the ones that predominantly induce antibody-mediated immunity. Their influence is evident in conditions like lepromatous leprosy and various allergic disorders where, excessive antibody production can sometimes be part of the problem.
So different Th cells drive different kinds of immune responses, shaping how the body attacks. What about Th17? That's a more recently discovered subset, isn't it?
It is. Relatively speaking, Th17 cells have a significant role in host defense, particularly against extracellular bacteria and fungi. What's also notable is their contribution to the development of allergy and autoimmunity. It really highlights the delicate balance within the immune system, how an overactive or misdirected response can sometimes cause harm.
A double-edged sword sometimes. And finally, the CD8 plus cytotoxic T cells, the TC cells, the hit squad. What's their main job?
TC cells are incredibly important. They are indeed the direct killers that eliminate intracellular pathogens like viruses.
How do they do that?
Well, when a cell becomes infected, say with a virus, it presents fragments of the viral proteins on its surface using class I MHC molecule.
Right, the class A presentation.
And exactly. This allows TC cells to recognize that specific infected cell and precisely destroy it, preventing the virus from replicating further and spreading. This is also why they are critically involved in organ transplant rejection. They recognize the foreign MHC molecules on the transplanted cells as a threat that needs to be eliminated.
It's truly incredible how these systems, from the broad innate defenses to the highly specific memory-driven adaptive responses, work together in such an intricate, coordinated fashion. But what happens when these fortresses, no matter how sophisticated, are weak? That brings us to the challenging topic of primary immunodeficiency disorders.
Right, so a small but clinically significant proportion of children who present with frequent or severe infections turn out to have an immunodeficiency. But it's really crucial for us to understand that while primary immunodeficiencies are our focus here, secondary causes are far, far more common in practice and
Yeah,
sometimes overlooked.
that's a really important distinction.
Mhm.
You give us some key examples of what might cause a secondary immunodeficiency. What kind of conditions lead to acquired immune weakness?
Certainly. The most common cause of secondary immunodeficiency in children globally is infection with the human immunodeficiency virus, HIV. That's the big one. But it's definitely not the only one. Other significant causes include the immune suppression that can follow a severe measles infection, severe malnutrition, conditions like nephrotic syndrome where you lose proteins, or various cancers affecting the lymph system and particular malignancies. Even severe burns can compromise immunity.
Yeah, medications too, right?
Yes, certain medications, particularly things like high-dose glucocorticoids, cyclophosphamide, azathioprine, and diphenyldantoin, can profoundly suppress the immune system. And in a challenging cycle, severe chronic infections themselves can lead to secondary immunodeficiency, making individuals even more vulnerable.
So secondary immunodeficiencies are usually a consequence of something else, another condition, a treatment, an infection. How then do we define primary immunodeficiency disorders, PIDs? What makes them different?
PIDs are fundamentally different. There are conditions where the immune system's intrinsic machinery itself has a fundamental flaw. They are typically genetic or congenital defects that directly affect one or more of the major components of the immune system. So this could involve defects in the number or function of T lymphocytes, B lymphocytes, or both, leading to impaired antibody production. Or they can affect the number or function of phagocytes, those eating cells, or even specific components of the complement system we just discussed. These are inherent weaknesses, not acquired ones.
Okay, so this is where it gets really interesting for anyone trying to understand when to suspect something might be amiss. If you're wondering when to suspect a primary immunodeficiency, there are 10 crucial warning signs that medical professionals look for. These are critical markers, so let's go through them clearly. Keep these in mind. First, we look for 4 or more new infections in a single year. It's about that pattern of unusual frequency.
Right, recurrence is key.
Second, 2 or more serious sinus infections in a year. Not just a sniffle, but significant infections needing medical attention. Third, 2 or more cases of pneumonia in a year. Suggests the lungs' defenses are consistently failing. Fourth, if an individual is on antibiotics for 2 months or longer without any noticeable effect, this hints at a persistent or untreatable infection or a deeper immune issue. Fifth, and this is especially important in infants, is the failure to gain weight or grow normally. Infections can be a huge drain on resources.
A critical sign in pediatrics.
Sixth, we look for recurrent deep skin infections or organ abscesses. These go deep, difficult to clear. Seventh, persistent oral thrush or candidiasis elsewhere, especially beyond infancy. While common in young babies, persistence is a red flag. Eighth, the need for intravenous antibiotics to clear infections indicates standard treatments aren't enough.
Yeah, needing rabies suggests a severity or lack of response.
Ninth, 2 or more deep-seated infections like meningitis or cellulitis. These are life-threatening and suggest severe vulnerability. And finally, 10th, a family history of immunodeficiency. Given the often genetic nature of PIDs, this is a crucial piece of the puzzle.
Those 10 signs really paint a picture of ongoing, severe, or unusual infections that definitely warrant a deeper look. And once a PID is suspected, a meticulous diagnostic workup becomes essential. This involves a series of investigations, starting with initial screening tests.
What are those initial screening investigations, the first line of inquiry?
They typically include a total and differential leukocyte count, just to see the overall white blood cell picture, any abnormal numbers or types. We also examine leukocyte morphology, how the cells look, and the platelet count and size, as some PIDs affect these too.
Okay.
HIV serology is also a critical early test, given how common secondary immunodeficiency due to HIV is, and a chest X-ray can provide immediate clues, maybe about the thymus or signs of chronic lung infections.
And then, if those initial screenings raise flags, you move to more specific targeted investigations. What's on that comprehensive list to really pinpoint the defect?
Right. The specific investigations are quite extensive. We start with quantitative immunoglobulins, measuring the precise levels of IgG, including its subclasses, which is important, IgA, IgM, and IgE.
Measuring the antibodies.
Exactly. Then we assess functional antibody tests. These aren't just about quantity, but quality. Are the antibodies working? For instance, blood group isohemagglutinins check for functional IgM, and measuring anti-diphtheria and anti-tetanus antibodies, especially after vaccination, evaluates functional IgG responses.
So not just how much antibody is there, but if it's actually working. What about the cellular side, assessing the lymphocytes we talked about earlier?
For cellular immunity, flow cytometry is crucial again. We use it to identify and quantify lymphocyte subsets like CD3, CD4, CD8 for P cells, CD19 for B cells, CD16, CD56 for NK cells. This tells us if the populations are normal. We also test for specific markers like CD18 for leukocyte adhesion defect, a disorder affecting how immune cells get to infection sites.
Okay.
Beyond cell counts, we perform protein assays for specific genetic disorders, like looking for Bruton tyrosine kinase protein, which points to an X-linked deficiency, or the Wiskott-Aldrich syndrome, WS protein.
And how do you check if these cells are functionally active? Not just present, but doing their job.
Good question. For T cell function, we use functional cellular tests like mitogen stimulation tests. These measure how well lymphocytes respond and proliferate when stimulated, say by phytohemagglutinin. It tells us about their ability to react. For phagocyte function, we rely on tests like the nitroblue tetrazolium direduction test, or NBT, and the dihydroodamine assay using flow cytometry. These are particularly useful for diagnosing chronic granulomatous disease, CGD, that key defect in phagocyte killing.
That's very specific. What about the complement system? How do you test for deficiencies there?
For complement, we use CH50 and AH50 assays to check the overall activity of the classical and alternative pathways. Then we can measure levels of individual complement components to pinpoint where the breakdown might be. We also perform a mannan-binding lectin assay for the lectin pathway. And for certain metabolic immunodeficiencies, enzyme assays are needed, like for adenosine deaminase and purine nucleoside phosphorylase, as deficiencies there severely impact immune cells. Finally, cellular immunity can also be assessed through delayed skin tests, using common antigens like candida or tetanus toxoid to see if a cell-mediated inflammatory response happens, indicator of functional T-cell memory.
That's a really comprehensive lineup of tests, designed to leave no stone unturned. But I imagine it's also important to rule out things that look like immunodeficiency but aren't, right? Misdiagnosis must be a trap.
Oh, absolutely critical. Before concluding a primary immunodeficiency diagnosis, you have to exclude conditions that mimic it. Things like severe gastroesophageal reflux, which can cause recurrent lung infections from aspiration, or Cardiganer syndrome, affecting cilia, leading to chronic respiratory problems, or cystic fibrosis with its thick mucus and infections.
Right, they cause infections, but the immune system itself might be fine.
Exactly. All of these can cause symptoms that might initially suggest an immune defect. Careful differential diagnosis is absolutely essential to ensure the correct diagnosis and, therefore, the appropriate treatment. What's truly fascinating here, I think, is how these specific genetic defects can lead to such a diverse range of vulnerabilities, each with its own unique clinical signature, its own challenges. Let's maybe delve into some of the most critical primary immunodeficiency disorders, starting with those affecting cellular and/or combined immunity, basically, where T cells, and often B cells too, are severely compromised.
All right, let's start with severe combined immunodeficiency, or SCID. That sounds, well, severe. Like a complete breakdown.
It is, devastatingly so. Children with SCID typically present in early infancy, very early, with severe, persistent, often life-threatening infections. And it's due to a broad range of pathogens. Viruses, fungi like Pneumocystis cerevisiae, intracellular pathogens like mycobacteria, things a healthy immune system usually handles easily.
What are the signs?
A key clinical sign is usually the profound absence of tonsillar tissue and lymph nodes. You can't feel non-palpable lymph nodes. It reflects the lack of immune cell development. And in the lab, profound lymphopenia, a very low lymphocyte count, is characteristic. Stark.
And the prognosis.
Left untreated. Affected babies typically don't live for more than a few months. Overwhelming infection.
That's heartbreaking. What's the underlying genetic cause for this?
The most common form is X-linked, caused by mutations in the common gamma chain of interleukin-2, or IL-2 gamma chain. It's vital for multiple lymphocyte types. About a quarter of SCID cases are due to adenosine deaminase deficiency, an enzyme critical for lymphocyte metabolism. Interestingly, SCID caused by purine nucleoside phosphorylase deficiency might present a bit later, maybe with milder features, but still profoundly compromised, shows some variability.
Next, DiGeorge anomaly. Is that also a T-cell defect, but maybe with other systemic issues involved?
Yes, it's a condition with a spectrum of effects. D. anomaly arises from developmental defects in the embryogenesis of the third and fourth pharyngeal pouches.
Embryonic development.
Right. These pouches are crucial for developing several structures, including the thymus gland, where T cells mature. Clinically, it's characterized by an unusual facial appearance, hypertelorism, wide-set eyes, antemongoloid slant, upward eye slant, low-set ears, micrognathia, small chin, short feltrum, often a bifid uvula. Patients also frequently present with hypocalcemic tetany due to parathyroid problems and congenital heart defects, especially aortic arch anomalies. A key immune finding is an absent or severely underdeveloped thymus.
And the immune impact varies.
It does. About 20–30% of patients show a variable T-cell defect. It can range from just mildly increased susceptibility to infections all the way to severe disease requiring a thymic transplant or hematopoietic stem cell transplant.
So a broad spectrum of issues, not just immune. What about Wiskott-Aldrich syndrome, or WAS? That name rings a bell.
Wiskott-Aldrich syndrome was, yes. It's an X-linked recessive disorder, so it primarily affects boys. It's caused by mutations affecting the WAS protein. This protein is found in lymphocytes and platelets, and it's crucial for cell signaling and cytoskeletal organization.
Okay, and clinically, what does it look like?
Clinically, it presents with a classic triad. Eczema, often starting in early infancy, sometimes mimicking atopic dermatitis. Thrombocytopenia, which is a low platelet count, and specifically associated with small-sized platelets, leading to bleeding issues. And significant immune vulnerability.
And how does that immune defect translate to specific vulnerabilities? What infections are they prone to?
Due to impaired responses to polysaccharide antigens, patients with WAS are highly susceptible to severe recurrent infections, particularly with encapsulated bacteria, pneumococci, meningococci, and Haemophilus influenza.
The ones conjugate vaccines target.
Precisely. The clinical presentation varies significantly. It can range from a fulminant course with repeated severe infections, the WAS spectrum, to a later presentation mainly with bleeding issues, the X-linked thrombocytopenia spectrum. There's also an increased long-term risk of lymphoreticular malignancies, cancers of the immune system. Specifically, there's severe IgM deficiency on top of defective T-cell signaling, which is secondary to deficient expression of a protein called CD43 in lymphocytes.
That's a truly complex picture. Blood clotting, skin, immunity, all affected. And ataxia-telangiectasia, what are its defining characteristics?
Ataxia-telangiectasia, or AT, is an autosomal recessive disorder. The gene is on chromosome 11, and its product regulates the cell cycle, playing a role in DNA repair.
Okay, DNA repair. And the clinical signs?
Its clinical hallmarks are progressive ataxia, lack of muscle coordination, typically starting in infancy. Telangiectasia, small, dilated blood vessels initially seen on the whites of the eyes. Recurrent sinopulmonary infections. Chromosomal breakage, making cells fragile, and increased sensitivity to ionizing radiation, like X-rays.
How bad is the immunodeficiency compared to WAS?
The degree of immunodeficiency in AT is generally less profound than in Wiskott-Aldrich syndrome, but still significant. Lab findings usually show reduced serum IgA, IgG2 subclass, and IgE levels. Lymphocyte proliferative responses are decreased, indicating T-cell issues, and the number of gamma-delta positive T-cells is increased.
It's remarkable how a single genetic defect can manifest in so many different ways, affecting multiple systems. What about hyper-IgM syndrome?
Hyper-IgM syndrome can result from multiple genetic causes, but the most common is a defect in CD40 ligand. This ligand is crucial for T cells to interact properly with B cells to allow for antibody class switching.
Bias switching.
Yeah, switching from producing IgM to producing other antibody types like IgG, IgA, IgE. Without that switch, patients exhibit profound immunodeficiency characterized by low levels of IgG, but paradoxically normal or even raised IgM levels, hence the name.
Oh, okay.
This unique profile makes them particularly susceptible to opportunistic infections, such as pneumocystis jirovecii. Some patients may also have associated autoimmune disorders where the immune system mistakenly attacks the body's own tissues.
Okay, let's move on to the humoral immunodeficiencies, primarily involving B cells and antibody production. Starting with X-linked, Bruton, agammaglobulinemia. Sounds like no antibodies at all.
Almost. It's a classic X-linked recessive disorder, so it almost exclusively affects boys. It's caused by a mutation in the gene for Bruton tyrosine kinase, or BTK. BTK is a protein crucial for B-cell development and maturation. Affected boys typically present in the second half of infancy with recurrent pyogenic or pus-forming bacterial infections, though later presentations can occur.
What are the physical signs?
Clinically, their tonsils and lymph nodes are usually atrophic, very small, or underdeveloped because they lack the B cells that normally populate these immune tissues. The key lab finding is the almost complete absence of B cells, CD19 positive cells in the peripheral blood, but their T cells, CD3 positive cells, are normal in number and function. It's a clear primary B cell defect.
And then there's common variable immunodeficiency, or CVI. How's it different from Bruton's? Both involve low antibodies, right?
They do, but CVID is different. It's a heterogeneous group of conditions, meaning various underlying genetic causes, all characterized by hypogammaglobulinemia, low antibodies, and variable defects in T cell number and function.
Variable T cell defects, too.
Yes. Unlike X-linked agammaglobulinemia, CVID usually presents later, often in childhood or even adulthood. Affected individuals often show marked lymphadenopathy, enlarged lymph nodes, and hepatosplenomegaly, enlarged liver and spleen. That's a stark contrast to the atrophic lymphoid tissue in Bruton's.
Yeah.
And the number of B cells, CD19 plus, is usually normal in CVID, another key difference.
Okay.
We might also see low levels of lymphocyte proliferation following mitogen stimulation, indicating some T cell functional defects. Genetically, mutations in several genes like ICOS, CD19, CD20, CD81, BAFFR, TACI, or TNFR-SF13C might be responsible. A significant feature of CVID is the frequent association with autoimmune disorders like leukopenia, thrombocytopenia, hemolytic anemia, arthritis, and patients require careful monitoring for lymphoreticular malignancies.
Given how common respiratory infections are, what about IgA deficiency? Is that always clinically significant?
IgA deficiency is actually one of the most common primary immunodeficiencies. However, and this is important, affected individuals usually do not have a clinically significant immunodeficiency. Yeah, many remain entirely asymptomatic, or they might experience recurrent mild respiratory infections, especially if they also have an IgG subclass deficiency alongside it. It's also worth noting these patients may occasionally evolve to common variable immunodeficiency later in life, so it warrants long-term observation even if initially benign.
And speaking of IgG, what's the significance of IgG subclass deficiency? You could have low levels of just one type.
Exactly. Children with a deficiency in one of the IgG subclasses can actually have normal or sometimes even elevated total IgG levels. This makes diagnosis tricky. You need specific subclass testing. Each IgG subclass has specialized roles. IgG1 protects against bacteria like diphtheria and tetanus. IgG2 protects against encapsulated bacteria like pneumococcus and Haemophilus influenza. IgG3 has important antiviral properties, and IgG4 has antiparasitic activity.
So a deficiency in just one subclass weakens a very specific type of defense.
Precisely, leading to particular patterns of infection.
And what about transient hypogammaglobulinemia of infancy? That sounds like it might resolve on its own, maybe physiological.
It is. Infants naturally show a physiological dip in immunoglobulin levels between 3 and 6 months of age. This is normal.
Why does that happen?
It's when the maternal IgG antibodies they got through the placenta have been broken down, catabolized, and the infant's own production hasn't fully ramped up yet. In some infants, this physiological dip is simply prolonged, maybe extending to 18-24 months. That's transient hypogammaglobulinemia of infancy.
How do you diagnose it then?
It's important to interpret serum IgG levels in infancy in the context of age-related normal ranges, or nomograms, to distinguish this from a true PID. Unlike X-linked agammaglobulinemia, B cell numbers are normal in these children. The good news is these children typically recover over time. Their long-term prognosis is excellent. Needs observation, not usually aggressive intervention.
Okay, shifting gears now to disorders of nonspecific immunity, specifically phagocyte defects. Let's talk about chronic granulomatous disease, or CGD. Sounds like a problem with those frontline engulfing cells.
It is. Chronic granulomatous disease, CGD, refers to a group of disorders with reduced activity of an enzyme called NADPH oxidase. This enzyme is absolutely crucial for generating superoxide radicals, which phagocytic cells need to effectively kill certain ingested pathogens. Without it, they can engulf bacteria, but they can't efficiently destroy them.
They trap them, but can't kill them properly.
Exactly. The disease is X-linked in about half of patients due to mutations in the GP91Fox gene. Other cases have autosomal recessive inheritance involving mutations in related genes like P47Fox, P67Fox, or P22Fox. Children with CGD present with recurrent, often life-threatening infections starting in early infancy.
What kind of infections are they most vulnerable to, given this specific killing defect?
They are chiefly caused by catalase-positive bacteria, things like Staphylococcus aureus and Serratia, and fungi like Aspergillus. These pathogens are particularly good at neutralizing the body's limited oxidative killing mechanisms. Clinically, you'll see things like persistent pneumonia, prominent lymphadenitis, severe inflammation of lymph nodes, multiple liver abscesses, and osteomyelitis, particularly of the small bones of the hands and feet. Diagnosis is suggested by screening with the NBT test and confirmed by the dihydrotamine assay using flow cytometry, which directly measures that oxidative burst.
And what about complement component deficiency, another aspect of nonspecific immunity? How does a missing complement protein manifest?
Individuals with deficiencies of the early complement components C2, C3, or C4 may present with recurrent bacterial infections as their ability to kickstart the complement cascade is impaired. Those with deficiencies of the later components C5 through C9 have a particular vulnerability to Neisseria infections like meningitis.
Why Neisseria specifically?
Because those later components form the MAC, the membrane attack complex, which is crucial for killing Neisseria bacteria. There's also an interesting autoimmune link. Systemic lupus erythematosus, SLE, may occur in individuals with C2, C4, or C1q deficiency. And a deficiency of C1 esterase inhibitor is uniquely associated with hereditary angioneurotic edema characterized by recurrent non-itchy swellings, which can be life-threatening if they affect the airway.
Lastly, in this category, we have hyper-IgE syndrome.
Hyper-IgE syndrome is typically an autosomal dominant disorder caused by mutations in the STAT3 gene, which plays a role in cytokine signaling.
Okay, STAT3.
And clinically, it presents with recurrent cold staphylococcal abscesses. They're called cold because they lack the usual heat and redness due to a dampened inflammatory response. Patients also frequently experience pneumonia, often with pneumatocytes, those thin-walled air cysts in the lung. They often have retained primary teeth and a markedly elevated serum IgE concentration, often over 2,000 IU/ml, hence the name hyper-IgE.
That's a comprehensive overview of how these immune fortresses can falter, each with its distinct clinical presentation. But what about treatment? What options are available for these primary immunodeficiency disorders, from lifelong management to potentially curative options?
Right, treatment varies greatly. Hematopoietic stem cell transplantation, or HSCT, is truly the treatment of choice for most forms of significant cellular immunodeficiency.
Like SCID.
Exactly. Conditions like SCID, Wiskott-Aldrich syndrome, hyper-IgM syndrome, the timing is crucial here. Ideally, the procedure should be done in early infancy for the best outcomes before irreversible damage from infections occurs.
That's a definitive, often curative approach for some. What about other forms of treatment, particularly for antibody deficiencies, where you can replace what's missing?
Yes, for children with X-linked agammaglobulinemia, IgG2 subclass deficiency, and common variable immunodeficiency, the primary treatment is regular administration of intravenous immunoglobulin, or IVIG.
Giving them antibodies directly.
Precisely. Usually every 3-4 weeks. This therapy literally provides the antibodies their bodies can't produce. While it can be expensive, IVIG therapy results in a satisfactory quality of life by preventing those severe recurrent infections.
And for some of the other specific disorders we discussed, are there tailored therapies?
Absolutely. Patients with IgA deficiency, as we said, generally don't require specific therapy, as it's often clinically mild. However, for some children with IgG1 and IgG3 subclass deficiency, prophylactic therapy with antimicrobials, usually cotrimoxazole, is required to prevent recurrent infections, especially respiratory ones.
And for chronic granulomatous disease, where the killing mechanism is faulty, what helps them?
For CGD, long-term cotrimoxazole and itraconazole prophylaxis has significantly improved management by preventing severe fungal and bacterial infections. Interferon gamma is also used for treating life-threatening infections, as it helps boost immune cell activity. And increasingly, HSCT is being used in these patients as well, offering a potential cure.
What about complement deficiencies?
Plasma infusions may be useful for patients with complement deficiencies, as they replenish the missing proteins, providing a temporary functional cascade. For C1 esterase inhibitor deficiency, prophylactic therapy with drugs like tranexamic acid, danazol, or stanozolol can result in significant improvement by stabilizing the system. If there's laryngeal involvement with airway compromise, a medical emergency injections of synthetic C1 esterase inhibitor are required immediately, life-saving.
It's incredible how specific and targeted the treatments are becoming.
Yeah.
And gene therapy, the cutting edge. How's that progressing here?
Gene therapy has actually seen remarkable success in this field. It has been successfully used in patients with X-linked SCID, chronic granulomatous disease, and Wiskott-Aldrich syndrome.
Wow.
It truly demonstrates the cutting edge of treatment, offering the potential for long-term correction of the underlying genetic defects by inserting a functional copy of the faulty gene. It's a remarkable testament to scientific progress in treating these devastating diseases.
This journey through immunity and immunodeficiency really highlights the incredible complexity of our body's defenses and the profound challenges when they falter. But now let's pivot to the power of prevention. Immunization, a field that has utterly transformed global health.
Okay, let's unpack the foundational concepts of immunization. First, what exactly is a vaccine? How does it train our body without making us sick?
Right. A vaccine is essentially a preparation containing either killed or live attenuated organisms, or sometimes just specific antigens from a pathogen. When it's administered to individuals who haven't been exposed before, it elicits an immune response. But crucially, it does so without causing the actual disease.
It's a practice drill.
Exactly, it's a controlled exposure, like a sparring session for your immune system, teaching it to recognize and fight a threat without experiencing the full-blown illness.
So it's training our body safely. And this leads to something called active immunity, right? The body doing the work itself. Correct. Active immunity is the protective response mounted by your own immune system. This happens after either a clinical or subclinical infection, or, of course, vaccination. This involves both humoral antibody-mediated and/or cellular cell-mediated immune responses. Your body actively learns and remembers.
How does that immune response develop initially, the first time you encounter something new or get that first vaccine dose?
That's the primary immune response. Following the very first exposure or the first vaccine dose, this response develops relatively slowly, usually over 3 to 14 days. It may or may not be strong enough initially to fully counteract an infection. That's why non-live vaccines often require multiple doses to build up that primary response.
Okay.
The antibody part of this involves IgM antibodies appearing first, then followed by IgG antibodies. It's the immune system's first learning curve, often a bit tentative.
And then the brilliance of immunological memory kicks in with the secondary response,
Yep.
right? This is where the real power of vaccination lies.
Exactly. When the host is re-exposed to the same infectious agent or gets a booster dose of a vaccine, the secondary immune response or booster response kicks in. This response is lightning fast. It induces high titers, high concentrations of high-affinity IgG antibodies, and it's usually sufficient to prevent the disease altogether.
And it lasts longer.
Yes, this protection typically lasts for several years, sometimes for life. This is why boosters are so crucial for sustaining protection. They leverage that built-in memory.
So active immunity is our body learning to fish, essentially. What about passive immunity? That sounds different, more like getting a direct shield.
You've got it. Passive immunity refers to receiving protection by the immediate introduction of preformed antibodies, either from animals or humans.
Preformed antibodies.
Yes. Classic examples are maternal IgG antibodies crossing the placenta to protect the fetus, or secretory IgA in breast milk protecting the nursing infant. It also includes the medical administration of immunoglobulin or anti-sera for specific conditions, like after a tetanus-prone wound or a rabies exposure.
So that's like getting a ready-made shield. What's the impact of that? How long does it last?
Well, these antibodies provide immediate protection. They can neutralize toxins or restrict viral multiplication right away. But, and this is the critical point, the effect is not sustained. Once those preformed antibodies are broken down by the body, the protection is gone. Your own immune system wasn't activated to produce its own memory. It's a temporary loan, providing immediate but fleeting defense.
Okay, immediate but temporary. And where do the terms immunization and vaccination fit into all this? People use them interchangeably sometimes.
They do, but there's a slight distinction. Immunization is the broader process of inducing immunity, whether it's active immunization via vaccines or passive immunization by giving antibodies. Vaccination, then, is specifically the process of administering vaccines. These predominantly elicit humoral responses like the H influenza vaccine or cellular immunity like BCG, or, as is the case with most modern vaccines, they elicit both humoral and cellular responses.
Got it. And sometimes vaccines need a little help to really get the immune system's attention, to make that lesson stick. That's where adjuvants come in, right?
Yes, exactly. Adjuvants are substances added to a vaccine formulation. They're unrelated to the actual organism, but serve to enhance its immunogenicity, basically, make the vaccine more effective at provoking a strong immune response.
How do they work?
Common adjuvants include things like aluminum hydroxide or certain lipids. They work by either stimulating lymphocytes nonspecifically, kind of like a general immune system wake-up call, or by enabling a slow release of the antigen. This gives the immune system more time to respond and build a robust memory.
And what about seroconversion and seroprotection? These sound like they relate to antibody levels after vaccination.
They are crucial for monitoring vaccine success. Seroconversion is the change from being antibody negative to antibody positive. This happens when detectable antibodies are induced in response to an infection or, more relevant here, vaccination.
So the body responded.
Right. Seroprotection, on the other hand, describes the state of actually being protected from disease because you have detectable serum levels of antibody. It's the ultimate goal, not just producing antibodies, but producing enough to provide meaningful protection.
Now, when we talk about how well a vaccine works, we often hear protective efficacy and vaccine effectiveness. Are those the same? They sound similar.
Not quite, and it's a really crucial distinction for understanding vaccine performance in different contexts. Protective efficacy is the ability of a vaccine to protect against disease, and it's typically assessed in highly controlled clinical trials. Ideal conditions.
Okay, in a trial setting.
Yeah, you can calculate it using a formula. Rate of disease in unvaccinated rate in unvaccinated times 100%. Vaccine efficacy depends on many factors: the vaccine strain, the dose, number of doses, the age and immune maturity of recipients, even maternal antibodies. Generally, live viral vaccines like measles and rubella and toxoids tend to have higher efficacy than, say, BCG and killed bacterial vaccines. Efficacy tells you what a vaccine can do under ideal conditions.
And then vaccine effectiveness is the real-world measure, how it performs out in the community.
Exactly. Vaccine effectiveness is the ability of a vaccine to protect the population from disease when assessed in the context of real-world immunization programs. It depends not only on the vaccine's intrinsic efficacy, but also heavily on program implementation factors, coverage rates, proper cold chain maintenance, correct injection technique, the age of recipients, all the real-world variables.
So it's usually lower than efficacy.
Usually, yes. But effectiveness can actually be increased significantly by the phenomenon of herd effect, where widespread vaccination provides indirect protection. It's measured using real-world disease rates or statistical methods comparing vaccinated versus unvaccinated groups, or through seroprevalence studies. It tells you what a vaccine actually does do in the messy reality of public health.
So efficacy is potential, effectiveness is reality. Got it. What about vaccine failure? When does that happen?
Vaccine failure simply refers to getting the disease despite having been vaccinated. There are two main types. Primary vaccine failure is when the recommended dose or doses just fail to induce an immune response at all. The body didn't learn the lesson, didn't seroconvert. Secondary failure is when the disease occurs even though the individual did mount an immune response initially. This suggests that immunity waned over time or wasn't strong enough to completely prevent disease when challenged later.
Is failure common?
Failure is rare with highly effective vaccines like measles, diphtheria, and tetanus. Primary failure can sometimes occur with oral poliovirus vaccine due to interference factors. Secondary failure, where immunity wanes, is seen more with vaccines like BCG, pertussis, and typhoid. This just reinforces why understanding these nuances is important. No vaccine offers 100% absolute protection for every single person, forever.
Now that we understand the nuts and bolts of how vaccines work, let's zoom out again and look at how immunization functions in large-scale public health strategies. It's not just about individuals, it's about populations.
Absolutely. When we talk public health, mass immunization is a really powerful strategy used to contain, eliminate, or even eradicate diseases on a broad scale. And those terms contain, eliminate, eradicate. They have very specific epidemiological meanings. They represent different levels of success.
What's the difference between disease control, elimination, and eradication? They sound like steps on a ladder.
They are distinct steps, each representing a higher level of achievement. Disease control means reducing the incidence, prevalence, morbidity, or mortality of a disease to a level where it's no longer a major public health burden. But, and this is key, it still requires continued intervention measures to keep it at that reduced level.
Like keeping it in check.
Exactly. Think of seasonal flu control.
And disease elimination.
Yeah.
That sounds like a bigger win, maybe regionally.
Disease elimination takes it a step further. This is reducing the incidence of an infectious disease to zero in a defined geographical area. No endemic transmission persists in that region. However, continued measures are still required to prevent the reestablishment of transmission from outside that area. Polio elimination in India is a great example of this level of success.
So it's gone from a specific region, but not necessarily the whole planet. And then disease eradication is the ultimate goal, the global triumph.
Precisely. Disease eradication is the permanent reduction of the worldwide incidence of infection caused by a specific agent to zero. Crucially, once a disease is eradicated, intervention measures are no longer required anywhere in the world. The pathogen itself has been permanently removed from human circulation. Smallpox is the only human disease so far that has achieved this monumental status.
Incredible. And what about disease extinction? Is that even possible?
Disease extinction is the final theoretical stage. It means the specific infectious agent no longer exists at all, not in nature, not even in laboratories. It's an aspirational goal, maybe, but eradication is the highest practical and achievable public health target for infectious diseases currently.
One of the most critical concepts here, and one that gets talked about a lot, is herd effect, or herd immunity. It's fascinating because it shows how individual vaccination benefits the whole community. Can you break that down?
This is a truly critical concept for public health. The herd effect, or herd immunity, occurs when a large proportion of susceptible individuals in a population are protected from infection through widespread vaccination.
How does that work indirectly?
When this happens, the chain of transmission is broken or at least significantly slowed down. This is because vaccinated individuals are less likely to carry and spread the microorganism. This, in turn, significantly decreases the risk of disease even among those who are unimmunized or cannot be vaccinated, like infants too young for certain vaccines or immunocompromised individuals. It's indirect protection, shielding the vulnerable.
So it's community protection, not just individual. Are there situations where herd immunity is harder to achieve, where it's less pronounced?
Yes, definitely. The herd effect is less marked for vaccines that protect only against the disease itself, like diphtheria toxoid, rather than preventing the infection and transmission, like measles or OPV. It's also less effective for vaccines with lower intrinsic protective efficacy, like pertussis and typhoid historically. And it doesn't really apply much to diseases where humans aren't the main reservoir, like tetanus, where the bacteria lives in the soil. In these cases, even high vaccination rates might not completely break the chain of infection or protect the unvaccinated.
But despite these nuances, herd immunity is a cornerstone of global health efforts, isn't it? Essential for elimination goals.
Absolutely. The herd effect was a core strategy for eradicating poliovirus and is vital for controlling measles epidemics. Herd immunity specifically refers to the proportion of immune individuals in a population, and the minimum proportion of a population that must be immunized to eliminate or stop sustained transmission of a disease is called the herd immunity threshold. Reaching and maintaining this threshold is essential, and it varies depending on how infectious the pathogen is.
And speaking of population-level changes, what is an epidemiological shift? This sounds like it could be an unintended consequence of vaccination sometimes.
An epidemiological shift refers to a significant change in the pattern of disease within a population following widespread immunization. It can be positive, but sometimes challenging. For example, a positive shift. Immunization with trivalent OPV caused the selective extinction of type 2 poliovirus because the vaccine was highly effective against that subtype.
Yeah.
However, another example. Sometimes, with partial immunization coverage, some diseases like hepatitis A, varicella, or rubella can shift to affect older individuals.
Why does that happen?
Because the virus still circulates, but now it encounters a population where younger people are protected, but older people who missed vaccination or whose immunity waned are still susceptible. And unfortunately, these diseases often cause more severe outcomes in older individuals. This highlights the need for high, sustained coverage across all age groups.
Okay, let's unpack this. We've talked about the why and how of immunization on a grand scale. Now, what makes a good vaccine? What are the different scientific approaches? Understanding these design principles is key to mastery.
Right. A good vaccine needs several key characteristics to be effective and widely adopted. It should be easy to administer, ideally induce permanent immunity, be free of toxic substances, have minimal side effects, and remain stable for a prolonged time, even in challenging storage conditions. The timing of administration depends on a careful assessment, the recipient's ability to respond, the typical age of disease, and the practical feasibility of the schedule.
So it's a balance of cutting-edge science and real-world practicality. Let's start with the classic. Live vaccines, or live attenuated vaccines. How do they work, and what makes them so potent?
Live attenuated vaccines work by actually infecting the recipient and replicating within their body, much like a natural infection would.
Replicating.
Yes, this replication is key because it elicits robust cellular and humoral immune responses, providing broad and strong protection. The crucial difference is they are attenuated, weakened, so they typically don't cause the actual disease, except very rarely in severely immunocompromised hosts. Often a single dose is sufficient to induce lasting immunity, though some, like OPV, might need multiple doses to really establish infection in the gut mucosa.
Do maternal antibodies interfere with live vaccines? That's a common concern for infants.
Yes, that's an important consideration. Residual maternal antibodies can sometimes neutralize the vaccine organism before it establishes infection, interrupting the immune response. This is why vaccines like measles and MMR are typically given after 9 months of age when maternal antibody levels have naturally declined.
Okay.
However, it's worth noting maternal antibodies do not interfere with BCG, which primarily induces cell-mediated immunity, or OPV, which infects the gut mucosa locally. An added benefit is that live vaccines can sometimes confer herd immunity because the replicating virus can be shed, potentially boosting immunity in close contacts, though this needs careful management. A drawback, though, is their potency is very sensitive to storage and transport, demanding a robust cold chain.
Okay. And what about killed vaccines or inactivated vaccines? They sound like a different approach, maybe safer in some contexts because they don't replicate.
They are. Killed vaccines are prepared by growing the organisms and then inactivating them, usually with heat or chemicals like formalin. Unlike live vaccines, they don't cause infection or replicate. Instead, they present the immune system with the antigens directly to elicit a protective response.
So no risk of causing the disease itself.
Right. Interference by maternal antibodies is less significant with killed vaccines. However, because the organism can't replicate to amplify the immune signal, multiple doses are typically required to build and maintain immunity. The immunity they confer is generally not permanent. Booster doses are necessary for prolonged protection. Many killed bacterial vaccines and some viral ones, like influenza, can be associated with more significant local and systemic reactions compared to live vaccines.
So live vaccines mimic infection, killed vaccines show the mugshot. What about toxoids? These target bacterial toxins, not the bacteria themselves.
Toxoids are specialized. They are modified and purified toxins produced by bacteria, like diphtheria or tetanus toxins. They're inactivated, so they're not harmful, but crucially, they retain their ability to stimulate a protective immune response against the toxin.
How are they given?
For primary immunization, they're typically given in multiple divided doses. This helps decrease adverse effects at each shot while ensuring high antibody titers are elicited. Like killed vaccines, booster doses are required to sustain protection as immunity wanes.
And with all the advances in genetic engineering, we also have subunit vaccines. This feels like the most modern approach, targeting only what's necessary.
Indeed. Subunit vaccines include specific viral or bacterial antigens, often produced using recombinant DNA technology or genetic engineering. This allows for highly pure and specific antigenic components, minimizing extraneous material and potential side effects from other parts of the pathogen.
This is where we can really zoom in on the difference between polysaccharide and conjugate vaccines. This is a key aha moment, especially for protecting young children. They sound similar, but their effects are vastly different.
Absolutely. It's a profound distinction and a major breakthrough. Let's compare them directly. First, consider the polysaccharide vaccine. Its component is just the long-chain carbohydrate from the bacterial cell surface, the capsule. These polysaccharides primarily stimulate G cells, leading to a humoral immune response. Importantly, this activation is thymic independent. T cells are not required.
T independent.
The antibodies produced are chiefly IgM, and the titer, or concentration, is typically low. The duration of protection is brief. And critically, they show poor efficacy in children under 2 years old.
Why is that?
Because their immature immune systems aren't yet developed enough to respond robustly to these T-independent antigens. Consequently, their booster response is also poor. Subsequent doses don't significantly boost immune memory.
So a polysaccharide vaccine is like showing the immune system a blurry picture. It recognizes it, but only briefly and not well in young kids. Now, contrast that with the conjugated vaccine, the innovation.
The conjugated vaccine is a true game changer, particularly for protecting infants. Its component is the same polysaccharide, but it's chemically attached, or conjugated, to a carrier protein. This carrier protein is usually something the host's immune system readily recognizes as foreign, like a piece of diphtheria or tetanus toxoid.
Why attach the protein?
This seemingly small act of biochemical engineering has profound implications. It makes the polysaccharide visible to the T cells. It converts a T-independent antigen into a T-dependent one. Ah, it recruits the T cells.
Exactly. This single design choice unlocks a far more robust T-cell-dependent immune memory, something the old polysaccharide vaccines couldn't achieve. As a result, it stimulates both B and T cells, leading to a comprehensive humoral and cellular response. It induces both IgM and, crucially, high-affinity IgG antibodies, and at a much higher titer. The duration of protection is significantly longer and more consistent. Importantly, conjugated vaccines are highly effective in infancy, overcoming that age limitation. And finally, they elicit a strong, satisfactory booster response, allowing for sustained, robust immunity.
Wow.
This innovation fundamentally changed childhood vaccination, especially against encapsulated bacteria like Hib and pneumococcus. That's a huge difference. By attaching a protein, you essentially flag it for the T cells, orchestrating a much stronger, longer-lasting, and more comprehensive immune memory. That really explains why conjugate vaccines have been such game changers.
Okay, now that we understand the types of vaccines, let's talk logistics. Vaccination routes and principles. How are these delivered, and what are the key rules for administration to ensure effectiveness and safety?
Vaccination routes are critical. The intramuscular IM route is the most common. Vaccines like hepatitis A and B, DTP, Hubu, pneumococcal polysaccharide, inactivated polio, influenza all given IM. In infants, the preferred spot is the anterolateral aspect of the thigh good muscle mass there. In older kids and adults, it's the deltoid muscle in the upper arm.
Why not the buttocks?
Important point, avoid gluteal administration. Risk of hitting the sciatic nerve, and for some vaccines like hepatitis B, it's actually less effective there. If you have to give 2 IM shots in the same thigh, separate them by at least 1 inch, and always use separate sites if giving a vaccine and an immunoglobulin at the same time. Okay. And the subcutaneous SC route, just under the skin.
Yes, into the fatty tissue just beneath the skin. Preferred locations. Anterolateral thigh in infants, upper outer aspect of the triceps in older children. Examples given SC include measles, mumps, rubella, MMR, varicella, yellow fever, GHAI, meningococcal and pneumococcal polysaccharide, and IPV.
Then there's intradermal ID, right into the skin layers.
Intradermal injections go into the skin itself, usually over the deltoid, creating a small bleb or wheal. Examples are BCG, fractional doses of IPV, and rabies vaccine, often used for localized immune response or dose sparing.
And the non-injectable routes, much nicer for the patient.
Definitely. The oral route is used for vaccines like attenuated poliovirus, OPV, and rotavirus, which need to replicate in the gut for mucosal immunity. And the intranasal route is used for the live attenuated influenza vaccine, targeting the respiratory mucosa.
Beyond the roads, there are crucial principles of immunization that ensure safety and effectiveness. What are some key considerations professionals need to master?
Compliance with the recommended dose and route is absolutely essential. There are several key principles. For instance, different live vaccines, oral, parenteral, intranasal, can be given simultaneously. But if not given simultaneously, you need an interval of at least 4 weeks between them to avoid interference.
Okay, 4 weeks for live vaccines, if not simultaneous. What about other types?
Different types of inactivated or subunit vaccines offer more flexibility. They can be administered simultaneously or at any interval between their doses. Now, for 2 doses of the same vaccine, a minimum interval, usually 4 weeks, is necessary for adequate immune response. Rabies vaccine is a notable exception with some specific schedules.
So flexibility between different types, but allow time between doses of the same vaccine. What if you need to give multiple shots at once?
When necessary, 2 vaccines can be given in the same limb, preferably the anterolateral thigh for IM shots, ensuring they're at least 1 inch apart. A very practical point. A delay or lapse in a dose doesn't mean you restart the whole series, just give the missed dose and resume the schedule.
That's good to know.
Also, never mix different vaccines in the same syringe unless the manufacturer specifically approves it. It can affect potency or cause reactions.
And after the shot, observation period.
Yes, patients should always be observed for immediate allergic reactions for at least 15 to 20 minutes after immunization. Allows for prompt management of rare severe reactions like anaphylaxis.
There are lots of misconceptions about when not to vaccinate, leading to missed opportunities. What things are not contraindications?
Right, it's important to clarify. Immunization is not contraindicated in minor illnesses like a common cold. Not in premature infants, they generally respond well. Not usually in individuals with allergies, unless specifically to a vaccine component. Not in malnutrition, in fact, it's often more crucial for them. Not after exposure to an infection and not during antibiotic therapy. These are common reasons people delay unnecessarily.
So when are live vaccines absolutely contraindicated? Critical safety point.
Live vaccines are absolutely contraindicated in individuals with inherited or acquired immunodeficiency and during therapy with high-dose immunosuppressive drugs. The attenuated virus might cause actual disease in a severely immunocompromised host. However, a short course, less than 2 weeks of low-dose steroids might be an exception.
And does giving immunoglobulin interfere with vaccines?
Yes, immunoglobulins can interfere with the immune response to certain live vaccines, like MMR, which is why specific intervals are needed, but they do not interfere with OPV, yellow fever, or oral typhoid vaccines. Conversely, some vaccines, like hepatitis B, tetanus toxoid, and rabies, can be given concurrently with their corresponding immunoglobulin, providing both immediate passive protection and starting active immunity. Finally, active immunization should follow exposure to certain diseases, rabies, measles, varicella, tetanus, hepatitis B, providing crucial post-exposure protection. Right, connecting this to the bigger picture, national immunization programs are incredible public health undertakings. India's journey provides a fantastic case study in how these evolve, adapting to disease burden and scientific advances. The choice of vaccines for a national schedule is complex. It's based on disease burden, vaccine availability, cost-effectiveness, program coverage potential, and sustainability, a real balancing act.
It's not just about what's available, but what makes sense for that population. So what are the key milestones in India's national immunization program? It's been a long evolution.
It started with the WHO's Expanded Program of Immunization, EPI, in 1974. India adopted it in 1978, initially focusing on BCG, DTP, and OPV, mainly in urban areas.
So selected at first, how did it span?
In 1985, the Universal Immunization Program, UIP, launched, significantly improving nationwide coverage and adding the measles vaccine. Crucially, it established a nationwide cold chain, a huge logistical feat. Then, in 1995, the Pulse Polio Immunization Program began, instrumental in controlling and eventually eliminating polio. The UIP has remained core to subsequent health programs like child survival and safe motherhood, reproductive and child health, and the National Rural Health Mission, supported by groups like GHAI.
So a continuous evolution, adding new protections. What were some significant vaccine additions over the years?
Key additions include hepatitis B starting in 2002, nationwide by 2010, Japanese encephalitis, JE, vaccine in endemic areas in 2006, a second dose of measles in 2011. A big one was the pentavalent vaccine in 2013, combining DTP plus HBV plus high B into one shot, greatly reduced the number of injections.
This makes a difference.
Then inactivated poliovirus vaccine, IPV, in 2015-16. Rotavirus vaccine in 2016, human papillomavirus HPV vaccine also started introduction in 2016, the measles rubella vaccination campaign in 2017, and pneumococcal conjugate vaccine, PCV, also in 2017. The program started with 4 vaccines for 6 illnesses, but now provides coverage against 13 childhood infections. Massive expansion.
Incredible growth. But despite this progress, there was still a coverage gap leading to a targeted effort, Mission Indradhanush.
Yes. Despite 3 decades of UIP, surveys in 2014 showed only about 65% of infants received full immunization, a significant gap. So the government of India launched Mission Indradhanush in December 2014. The goal was ambitious: rapidly strengthen UIP and achieve over 90% full immunization coverage for infants by 2020.
Why Indradhanush, the rainbow?
It takes its name from the 7 colors, representing the 7 diseases initially prevented by its target vaccines: BCG, OPV, pentavalent, TT. It focuses on completing immunization for all children under 2 and pregnant women. Intense efforts were concentrated in specific focus districts, initially 201, later expanded to 528, which had the most partially or unimmunized children.
And who are the boots on the ground for this? Requires huge coordination.
Absolutely. It heavily relies on the 3 A's, Anganwadi workers, ASHAs, accredited social health activists, and ANMs, auxiliary nurse midwives. These frontline workers are crucial for reaching everyone. By August 2017, it showed significant impact. The annual increase in immunization coverage jumped from 1% in 2014 to 6.7% in 2015. Shows what focused effort can do.
And it didn't stop there, leading to intensified Mission Indradhanush for an even bigger push.
That's right. Intensified Mission Indradhanush, IMI, launched October 2017. Objective: fully immunize over 90% newborns by December 2018. Implemented through week-long immunization drives each month. Use additional strategies. Need-based interventions involving non-health departments, enhanced accountability, even vaccination on demand up to 5 years. It specifically targets left-out and drop-out sites in selected districts and urban areas with low-coverage slums, nomadic sites, outbreak areas, places without ANMs, hard-to-reach populations, incredibly targeted microplanning.
So while the national program sets the baseline, there's another influential body, The Indian Academy of Pediatrics, IAP. How do their recommendations compare? Do they always align?
The IAP's Advisory Committee on Vaccines and Immunization Practices, ACVIP, broadly endorses the National Immunization Program. However, they often recommend certain additional vaccines based on regional disease burden and the availability, safety, efficacy of newer vaccines that might not be universally adopted yet due to cost or logistics. Essentially, the IAP often provides a preferred schedule that might include more vaccines or differ slightly from the national program. It reflects what's considered ideal based on current evidence versus what's feasible nationwide. It's more aspirational, guiding future expansions.
So what does this all mean for us, the learner? Let's take a closer look at some common vaccines and understand their nuances, their core principles, public health significance, starting with BCG vaccine.
Okay. The BCG vaccine, Bacillus calmette-guerin, contains live attenuated Mycobacterium bovis bacteria. In India, the Copenhagen Danish 1331 strain is primarily used. It comes as a powder, needs careful reconstitution with sterile saline. It's quite sensitive to heat and light, loses potency fast once reconstituted, requires careful handling in cold chain.
And how effective is it? Tuberculosis is a huge challenge.
BCG primarily induces cell-mediated immunity. Meta-analyses show moderate efficacy against primary infection and pulmonary TB. However, and this is crucial for its use, it provides satisfactory protection over 50% against the severe disseminated forms of TB in children, like miliary TB and tubercular meningitis, and it significantly reduces mortality risk from these severe forms.
So not perfect prevention, but prevents the worst outcomes in kids. Why give it at birth? And the specific site?
Given at birth because childhood TB can be severe and disseminated. Vaccination in infancy prevents serious outcomes. Also, maternal antibodies don't interfere with BCG's cellular response, so it's effective early. Plus, giving it at birth promotes compliance. Conventionally, it's given intradermally into the skin at the insertion of the deltoid on the left shoulder. This specific site allows easy identification of the characteristic scar later, proof of vaccination. After vaccination, a papule forms, ulcerates, and heals by scarring over a few months. That's the normal reaction.
What about adverse reactions beyond the expected local response?
If injected too deeply, subcutaneously, it can cause persistent ulceration and swollen lymph nodes nearby, axillary or cervical lymphadenopathy. A more serious concern, though rare, is in children with severe immunodeficiency. They might develop disseminated BCG disease months later, underscores the importance of screening. Although immunity wanes, repeat BCG doses aren't considered useful. Research is ongoing for newer TB vaccines.
Next, let's talk poliomyelitis vaccines, OPV and IPV. Polio eradication, a huge success story for vaccination.
Indeed. Vaccination is the cornerstone for preventing paralytic poliomyelitis, that devastating disease caused by poliovirus types 1, 2, and 3, mostly affecting young children.
Yeah.
We have two main vaccines, the live attenuated oral poliovirus vaccine, OPV, and the inactivated poliovirus vaccine, IPV.
Let's start with oral polio vaccine, OPV. How does it protect against paralysis and transmission? That gut immunity is key, right?
Exactly. OPV contains live, weakened Sabin polioviruses. Given orally, they infect the intestinal mucosa and multiply there. This induces mucosal immunity, which is crucial. It protects the individual from paralysis, and it reduces their chances of getting infected by wild poliovirus. Critically, it reduces the duration and amount of wild virus they excrete if infected, interrupting fecal-oral transmission in the community. This gut immunity and reduced shedding made OPV so effective for eradication campaigns.
So it protects the individual and stops community spread. What about dosing and factors that might interfere?
Multiple OPV doses are essential for a good response and to overcome interference. Factors like maternal antibodies, other gut viruses, diarrhea, and cold chain breaks can affect its take. Vaccine take and seroconversion rates tend to be lower in developing countries due to these factors. Historically, trivalent OPV, types 1, 2, 3, was used. Type 2 immunity was highest, leading to global eradication of wild type 2 in 1999, a massive achievement.
And that's why the vaccine itself changed, right? Because OPV2, while effective against wild type, became the main source of vaccine-derived polio. A complex dilemma.
Exactly, a critical point. Since OPV2 inhibited OTV1 and 3 take and caused most vaccine-derived polio, VDPV, the trivalent vaccine was replaced by bivalent OPV, BOPV, as part of the polio endgame plan. OPV2 use was globally stopped in April 2016, a huge coordinated switch. OPV is very temperature sensitive. Potency is monitored by a vaccine vial monitor, VVM. While mild diarrhea isn't a contraindication, OPV is contraindicated in immunodeficient children and pregnant women and avoided in their household contacts due to transmission risk.
India's polio eradication journey is truly inspiring. How did OPV play a role there?
In India, OPV was given with DTP vaccines. Since 1995, kids under 5 also got it during pulse polio campaigns, National Immunization Days. This strategy, giving OPV to all young children simultaneously, effectively interfered with wild polio virus transmission. Combined with robust surveillance and targeting high-risk groups, wild polio virus was eradicated from India. Last wild case, type 1 reported Jan 2011, testament to sustained, high-coverage vaccination.
Phenomenal achievement, but as discussed, not without challenges, primarily the rare risk of vaccine-associated paralytic poliomyelitis, VAPP.
That's correct. While OPV was essential for eradication due to gut immunity, the live virus could rarely regain neurovirulence. This led to VAPP, occurring in about 1 in 1.5 million recipients, mostly linked to OPV3 recipients or OPV2 contacts. Furthermore, outbreaks could also be caused by circulating vaccine-derived poliovirus, CVDPV virulent strains formed by mutation of OPV, chiefly OPV2. These spread rapidly in low-coverage areas, causing outbreaks. Highlights the balance needed with live vaccines.
And this is where the inactivated polio vaccine, IPV, comes in, offering a different approach, especially regarding safety.
IPV is a suspension of formaldehyde-killed Salk poliovirus. Unlike OPV, it primarily induces humoral immunity antibodies in the blood, though it can also induce some pharyngeal and possibly intestinal mucosal antibodies. The current enhanced potency IPV, EIPV, is highly immunogenic, 99% seroconversion after 2-3 doses. While maternal antibodies might slightly interfere if started at 6 weeks, IPV has excellent efficacy in preventing paralysis and, crucially, does not cause VAPP.
Safer for the individual, but maybe less effective at stopping transmission compared to OPV.
Generally, yes, but its safety advantage has led countries with sustained eradication to switch to exclusive IPV use, often after a phase of combined OPV-IPV use.
So it's safer, even if it doesn't induce the same level of gut immunity. How have these considerations shaped recommendations in India moving towards a blended strategy?
Since Feb 2014, WHO no longer recommends an OPV-only schedule globally, largely because IPV also protects against CVDPV2, a concern after OPV2 withdrawal led to declining population immunity. Most countries now use a sequential IPV-OPV schedule. This minimizes VAPP risk with prior IPV while ensuring mucosal immunity from OPV to interrupt any remaining wild virus circulation. Gets the best of both.
So safety first, then gut immunity. Yeah. What are WHO's specific recommendations for countries transitioning?
WHO recommends all OPV-only countries add at least 1 dose of IPV. A common primary series is 3 OPV doses plus 1 IPV dose, starting from 6 weeks. If only 1 IPV dose is used, often given at 14 weeks when maternal antibodies are lower, boosting immunogenicity. A major goal of the polio endgame plan is introducing IPV everywhere, strengthening routine immunization, and withdrawing OPV phased, starting with OPV2. A comprehensive global strategy.
And what's the long-term vision after global OPV withdrawal? Will we still need polio vaccination?
Evidence suggests VDPV or even wild OPV might resurface years later. So even after worldwide OPV withdrawal, national schedules should continue O2 IPV doses for at least 10 years to maintain robust immunity, full or fractional doses. While prioritizing IPV supply, experts suggest continuing a 2-dose fractional FIPV schedule. It's dose-sparing, 1/5 IM dose, and gives better immunity than a single IM dose. 2 fractional or 2 full IPV doses needed for 90% seroconversion. Giving FIPV at routine visits, 6-14 weeks, achieves high coverage.
So India's approach integrates these global insights.
Yes. IPV was introduced in India in 2015-16 with 2 fractional FIPV intradermal doses at 6 and 14 weeks. Kids continue BOPV on national immunization days. If the 6-week FIPV dose is missed, a full IM dose is given at 14 weeks. The IAP considers this moderately effective against OPV2, but prefers a more immunogenic 3-dose or 2 IM dose schedule if resources allow. IPV is also the choice for immunodeficient patients, including symptomatic HIV and their contacts. They shouldn't get OPV and need an extra IPV booster at 5 years. Both schedules retain the birth OPV dose, deemed necessary where transmission risk remains, and unlikely to cause VAPP due to maternal antibodies.
That's a lot of precision for one vaccine family, showing the dynamic nature of public health. Now let's move to the diphtheria, pertussis, and tetanus DTP vaccine. A staple, but one that's evolved significantly.
Indeed. The diphtheria component is diphtheria toxin, inactivated by formalin, a toxoid, adsorbed on aluminum hydroxide adjuvant, commonly combined with tetanus toxoid and whole cell pertussis bacteria in DTWP.
Does maternal immunity affect this one too?
Yes, maternal antibodies protect infants early on but can interfere with the DTP response, particularly pertussis. So vaccination needs to start within weeks of life, multiple doses required. Primary immunization with 3 doses induces good response to diphtheria and tetanus toxoids in 95–100%. Protective efficacy against pertussis is lower, maybe 70–90%, and wanes over 6–12 years. Importantly, immunization doesn't eliminate diphtheria carriage, just protects from disease.
So boosters are essential.
Exactly. Boosters needed to sustain protective antibody levels. Natural pertussis immunity also wanes, making boosters necessary into adolescence.
What about the common adverse reactions for DTWP? It has a reputation.
DTWP is commonly associated with local reactions, pain, redness, and systemic ones, fever, irritability, mostly due to the whole cell pertussis component. Incidence increases with doses, not used beyond 5 doses or 7 years. Historically, DTP was linked rarely to serious neurological issues, hypotonic hyperresponsive episodes, inconsolable cry, high fever seizures, encephalopathy, but conclusive causal evidence is lacking for most despite intense study.
And the absolute contraindications for DTWP.
Absolute contraindications. Progressive neurological disease, use DT or DT instead, anaphylaxis after a previous dose, encephalopathy within 7 days of a previous dose. Precautions are advised if a previous dose led to fever, 40.5 degrees C, 48 hours, hypotonic hyporesponsive episode, 48 hours, persistent inconsolable crying, 3 hours, 48 hours, or seizures, 72 hours. If a precaution event recurs, further pertussis vaccine is contraindicated. If DTP is contraindicated, complete the schedule with DT, diphtheria, tetanus only. DT is used up to 7 years. Beyond that, TD, reduced diphtheria, must be used.
So those adverse effects led to the acellular pertussis vaccine, or DTaP. What's the difference in design and impact?
DTaC development was driven by suspicion that whole cell pertussis toxin endotoxin caused the side effects. DTaC contains inactivated pertussis toxin plus 1 or more purified pertussis antigens like FHO, protactin, fimbrial protein, more selective.
How does this efficacy and safety compare?
Efficacy is generally similar to DTWP, but DTaP has a lower risk of systemic and local side effects. More comfortable. Despite this, DTaP isn't usually in national programs like India's due to cost. The IAP previously suggested DTaP for those who could afford it. However, recent studies suggest DTaP primary immunization efficacy might be slightly lower than DTWP for pertussis. So IAP now recommends only DTWP for primary immunization for better pertussis protection. Boosters at 16, 24 months, and 5 years can be either DTWP or DTaP. Contraindications are similar to DTWP. If contraindicated, complete with DT.
And what about adult pertussis vaccination? That's where reduced antigen acellular pertussis vaccine, Tdap, and reduced antigen diphtheria toxoid vaccine, PD, come in. Why is this important for older individuals?
Natural immunity to diphtheria and pertussis wanes. Many adults, especially in developed countries, become susceptible due to lack of natural boosting. Revaccination against diphtheria every 10 years might be needed. Tdap-T contains smaller amounts of diphtheria toxoid and acellular pertussis than DTP-DTaP, but are adequately immunogenic for boosters in adults and older children with fewer side effects. If giving primary or booster doses beyond age SIPN, use Tdap or TD. Tdap-TD can be used whenever tetanus toxoid. Tdap is indicated in children 7 years to also boost diphtheria immunity.
And the benefits of Tdap extend beyond the individual, right? The cocooning effect.
Yes. Tdap reduces pertussis in adults adolescents, who can transmit it to vulnerable infants. Vaccinating caregivers creates a protective ring. Reduced antigen means fewer side effects, but still induces a protective booster response. In India, Tdap usually has specific amounts of tetanus toxoid, diphtheria toxoid, and 3 acellular pertussis components. Contraindications same as DTaP-DTWP. Tdap may replace TDTT booster in kids 10 and adults, especially if 5 years have passed since the last TTTD.
Moving on to the tetanus vaccine, TT. Another fundamental vaccine. Huge impact on neonatal tetanus.
Expensive routine immunization of pregnant women with TT has dramatically reduced neonatal tetanus. 2 doses to pregnant women, second 4 weeks pre-delivery, provide passive immunity to the baby via transplacental IgG. The vaccine is tetanus toxin inactivated by formalin, absorbed onto aluminum salts, adjuvant. Heat stable, potent for weeks at 37 degrees Celsius. Efficacy is 80–100%. Protective antitoxin level is 0.01 IU/ml, though protection also depends on toxin load from a wound. Since tetanus can occur at any age, primary immunization starts in infancy with DTP. Boosters, DTT-TT, are given at 10 and 16 years, and for wound prophylaxis. Unimmunized children get 2 doses of TT 1 month apart.
Next up, measles-containing vaccines. Measles, MR, MMR, MMRV. Measles is highly infectious, can be severe, a critical vaccine.
Yes, measles vaccine, Edmiston Zagreb strain, is available alone or combined with rubella MR, mumps MMR, and varicella MMRV. Elicits both cellular and humoral responses. Infants are protected by maternal antibodies till 6-9 months. Vaccinating at 9 months balances early protection with ability to respond, as earlier vaccination might be blunted by maternal antibodies. Still, maternal antibodies cause primary failure in 15%, needing a second dose at 15 months. During outbreaks, might give earlier, 6 months, with a repeat dose later, doses or 1,000 infective units, loses potency fast after reconstitution, discard unused vaccine after 4 to 6 hours due to contamination risk, could lead to toxic shock syndrome.
What's the schedule like in India's national program, especially with MMR introduction?
The two measles doses, 9, 12, and 15, 24 months, are being replaced by MMR vaccine phased. Follows the nationwide measles rubella campaign, launched Feb 2017, giving one MMR dose to all kids 9 months, 15 years, regardless of prior status for rapid immunity. The IAP, recognizing mumps morbidity, recommends MMR instead of MR at 9 and 16, 24 months. IAP also recommends a third MMR dose at 4-6 years to boost anamnestic response.
And post-exposure prophylaxis for measles if someone's exposed and unimmunized.
Immunoglobulin for immunocompromised contacts and infants 6-12 months within 6 days of exposure, passive immunity. Unimmunized immunocompetent contacts 12 months should get measles or MMR vaccine within 72 hours of exposure, active post-exposure.
Building on that, let's talk measles, mumps, rubella MMR vaccine. Protects against 3 diseases, each with its rationale.
Right. Mumps in kids often mild, but in adolescents, adults can cause ophiritis or meningitis. Rubella usually benign, but vaccination prevents congenital rubella syndrome, devastating birth defects if mother infected during pregnancy. Most developed countries use MMR for primary immunization.
What's its composition and effectiveness?
Rubella component is RA273 strain. Mumps is live attenuated Gerald-Lynn strain, both grown in cell cultures. Elicits mucosal and systemic humoral-cellular responses. Seroconversion after single dose. 86-100% for mumps, 95% for rubella. Immunity is prolonged, but breakthrough infections reported 5 years later, confirming need for booster at 4 to 6 years. Safe, but avoid in pregnancy and immunodeficiency, live vaccine. Mild adverse effects common. Store lyophilized, use within 4 hours of reconstitution, a public health concern. Haphazard use without optimal 80% coverage can cause epidemiological shift. More adult cases, paradoxical increase in congenital rubella syndrome, like Greece in 1990s. High, consistent coverage is key.
Next, hepatitis B vaccine, HBV. Critical, especially at birth, preventing chronic liver disease and cancer.
HBV vaccine contains HBsAg, surface antigen, produced by recombinant DNA tech in yeast adsorbed on aluminum salt, adjuvant. While a 0-1-6-month schedule might be slightly more immunogenic, the national program integrates HBV into existing schedules, like with pentavalent, for compliance without extra visits. The birth dose is crucial for preventing mother-to-child transmission. Vaccination must start at birth if mother's HBsAg status is unknown.
What if the mother is known HBsAg positive?
Child should receive vaccine within hours of birth, AMD hepatitis B immunoglobulin, HBIg, within 24 hours at separate sites. Provides immediate passive HBIg and starts active vaccine immunity. Then follow a standard schedule. If HBIg isn't given, use an accelerated schedule, 0-1-2 months, plus an extra dose at 9-12 months. Combined HBIg plus HPV reduces transmission risk by 90% after exposures, needle stick, sexual, etc.
What about long-term protection?
Lifelong. Seroconversion 95% after 3 doses. Titer 10 ml protective. Usually induces long-term immunity. Routine boosters not usually recommended for healthy people. Special cases. Double dose and boosters may be needed in chronic kidney disease or immunodeficiency where titers might wane.
Next, Haemophilus influenza B Hib vaccine. Incredibly effective against serious childhood infections like meningitis.
Haemophilus influenza B Hib causes invasive infections, pneumonia, meningitis, bacteremia, especially in kids 2 years. Vaccination prevents 33% of related pneumonia, 90% of Hib meningitis. Huge impact. Antigen is the Hib capsular polysaccharide, polyribosilribdyl phosphate, PRP, conjugated, attached to carrier proteins like tetanus toxoid, mutant diphtheria toxin CRM197, or meningococcal outer membrane protein. Makes it work in infants. Available as monovalent or in combination with DTP Hep B or IPV. Safe, immunogenic. Efficacy 85-95%.
What's the schedule and how's it integrated?
Schedule depends on age at immunization start. Booster needed in second year for sustained protection. IAP recommends it for all kids up to age 5, since Hib mostly affects preschoolers. Older kids only need it if planned splenectomy or sickle cell disease. Now part of India's UIP, introduced as pentavalent vaccine, DTP, HBV, Hyde PRPT in 2015.
Another crucial one, given the global burden of pneumonia, pneumococcal vaccine.
Indeed. Streptococcus pneumonia causes 15–50% of community-acquired pneumonia, 30–50% of acute otitis media, 50% of pneumonia deaths, leading single cause of vaccine-preventable deaths globally and in India. 90 known serotypes, but 20 cause 80% of invasive disease. 13 serotypes cause 75% of invasive disease in young children. Kids 2 years especially susceptible.
And specific high-risk groups need it urgently.
Yes, regardless of age. Primary immunodeficiency, HIV, immunosuppressive therapy, organ transplant, sickle cell disease, asplenia, chronic cardiac, liver, pulmonary disease, chronic kidney disease and product syndrome, diabetes, kids with CSF fistula or cochlear implants. Life-saving for them.
What are the types? The conjugate superior again, right?
We're two main types. Unconjugated polysaccharide vaccine, PPV23, covers 23 serotypes. T-independent, poorly immunogenic 2 years, low memory. Doesn't reduce nasal carriage or provide herd immunity. Efficacy, 70% for invasive disease and high risk. Max 2 doses recommended.
So not ideal for young kids or public health impact.
Yes.
Then the conjugate.
Exactly. Pneumococcal conjugate vaccine, PCV, is the advancement. PCV13 covers 13 common serotypes linked to diphtheria carrier protein. PCV10 covers 10 serotypes, benefits. Robust T-dependent immune response, immunological memory. Reduced nasal carriage, giving significant herd effect. Efficacy 95–99% for invasive disease from included serotypes.
It sounds like the preferred choice, especially for kids.
Yes, IAP specifically recommends the conjugate vaccine due to high morbidity mortality in kids too. Beyond age 5, vaccination only needed in high-risk categories, who should also get PPV23 for broader coverage. Extra dose may be needed later for high risk. PCV launched in 3 Indian states May 2017 will extend nationally phase.
Another major cause of childhood illness, severe diarrhea. Rotavirus. How have vaccines tackled this?
Rotavirus is the chief cause of severe diarrhea in infants toddlers globally. Accounts for 6–45% of diarrhea hospitalizations in Indian kids. Natural infection doesn't give lasting protection. First licensed vaccine, RotaShield, withdrawn due to rare but serious intussusception risk, bowel obstruction.
Setback, but newer, safer ones emerged.
Yes. 2 live attenuated oral vaccines widely used, Rotarix, monovalent, and Rotatec, pentavalent, both 85–98% effective against severe rotaviral gastroenteritis. Also Rotavac, indigenous monovalent vaccine made in India, efficacy 49–54% against rotavirus diarrhea first 2 years. Inexpensive, safe, low intussusception risk, all 3 can be co-administered with OPV without compromising efficacy.
Any specific contraindications or precautions?
Avoid during acute gastroenteritis, might compromise take. Caution in infants at risk of intussusception, chronic GI disease, gut malformations. Immunization should finish by 8 months. Efficacy might be lower in countries with high infection rates, gut pathogen competition, but still has potential to prevent significant morbidity mortality. Introduced into India's UIP in 2016 in selected districts using Rotavac.
Now, a vaccine targeting a very different threat, but hugely important. Human papillomavirus, HPV, vaccine preventing certain cancers. Powerful preventive medicine.
Cervical cancer is second most common cancer in women, almost always due to oncogenic HPV. Serotypes 16 and 18 cause most invasive cervical cancer. Oncogenic types also cause anal, vulvar, vaginal, penile, or pharyngeal cancers. Non-oncogenic types 6 and 11 cause 90% of anogenital warts.
So the vaccine targets the specific strains causing cancer and warts, preventing cancer through vaccination.
Exactly. HPV vaccines contain self-assembling virus-like particles, VLPs, with recombinant L1 capsid protein, protect against 90% of infections with included serotypes, but no cross-protection against others. 2 main types. Quadrivalent Gardasil HPV4 protects against 6, 11, 16, 18, prevents related warts and neoplasia. Bivalent Cervarix HPV2 targets HPV 16 and 18, both highly effective, preventing high-grade cervical lesions and adenocarcinoma in situ. Most immunogenic at 9–14 years, protection lasts at least 5 years. Ideal age and need for boosters still being determined.
What's the status in India? Widely available.
Delhi and Punjab started school-based programs for girls 11–13 in 2016. IAP recommends it for all girls pre-sexual debut for max efficacy. Critical point. Immunization carries risk of complacency about routine cancer screening. Need to stress vaccination doesn't replace screening. No serious adverse events reported with HPV vaccine. Very safe.
Another geographically specific one, Japanese bee encephalitis. GHAI vaccine, crucial in endemic regions.
GHAI is significant cause of viral encephalitis in India, high fatality. Vaccination recommended for all kids, adults in highly endemic areas and travelers visiting 4 weeks. Older mouse, brain hamster, kidney vaccines discontinued 2005. 3 second-gen vaccines licensed in India now.
Tell us about these newer ones.
One is live attenuated cell culture vaccine, SA-1414-2, used in national program in hyperendemic districts. Genetically stable, unlikely neurovirulence. Single dose, 85–99% effective, but 2 doses recommended for sustained protection. Mass immunization, then routine vaccination used in endemic areas. Another is purified formalin inactivated SA-1414-2, GV, IC51, whole virus from vero cells, highly immunogenic, 90% seroconversion after 2 doses, lower adverse effect risk than live vaccine. Third is inactivated purified vero cell vaccine, Kohler strain Junvachi. Safe, effective, 93–98% seroconversion, offers choice.
Next, typhoid vaccine. Not in the national program yet, but recommended.
Not currently part of India's national program, but IAP recommends it for families who can afford it. Older wholesale inactivated vaccine no longer used. Common side effects needed frequent revaccination.
What about newer forms, oral and conjugate?
Oral vaccine, Ty21A, contains live attenuated bacteria, not marketed in India, induces gut immunity. 50–60% effective. Enteric-coated capsule, unsuitable for young kids. Avoid antibiotics around vaccination. Revaccinate every 3 years.
And the via-capsular polysaccharide vaccine.
Contains purified V-capsular antigen. Kids 2 years, 1 dose gives 50–75% protective efficacy, anti-IgG. Lacks memory response, needs revaccination every 3 years.
And the newest, conjugate typhoid vaccine.
Typhoid conjugate vaccines, 2 approved in India, recommended by IAP for kids 9 months. Vi-antigen coupled to carrier protein, like tetanus toxoid, preferred over polysaccharide due to stronger response, prolonged memory, better protection in young kids.
Moving to varicella vaccine, chickenpox. Usually mild, but complications can occur, especially in adults.
Varicella usually benign, self-limiting in healthy kids. Complication, pneumonia, encephalitis, secondary infection, more common severe in adults and immunocompromised. Vaccine contains live OCA strain virus, attenuated in cell culture. Elicits cellular and humoral response, 95–99% protective efficacy. Seroconversion after 1 dose, 95% young kids, 80% years. 2 doses seroconvert 90% 12 years. More robust lasting immunity. Breakthrough infection usually mild, a febrile, few lesions, mostly papules.
Why isn't it in India's national program?
Not a high public health priority compared to others. Vaccine expensive and needs very high coverage to prevent epidemiological shift to older ages, where disease is more severe. IAP recommends it if affordable. 2 doses recommended to reduce breakthrough waning immunity. Monovalent and MMRV preps available internationally show similar efficacy. IAP cautions using MMRV in 12–23 months olds due to higher adverse event rate, fever, rash, seizure, than separate MMR plus varicella. Older kids can get MMRV safely.
Who are the high-risk groups for varicella vaccination?
Indicated for chronic cardiac lung disease, asymptomatic HIV, CD4 15%, leukemia in remission 3 months off chemo, anticipated prolonged immunosuppression pre-transplant, prolonged aspirin therapy, stop aspirin 6 WKs post-vaccine. Also consider for unimmunized household contacts of immunocompromised, adolescents, adults without history, SBLA institutional settings, post-exposure prophylaxis effective if given to contacts within 72 hours, 70% protects efficacy.
Now, influenza vaccine, constantly changing strains, annual shot needed.
Influenza virus types A, B, C, subtypes based on surface antigens, hemagglutinin, neuraminidase. Mutations, antigenic drift shift mean frequent strain changes, why we need new shot yearly. Influenza A, B cause global epidemics, severe disease in young kids, elderly, immunocompromised, chronic illness. Available vaccines elicit strain-specific humoral response, 30–90% efficacy, composition reviewed annually by WHO.
What are the main types of flu vaccines?
Inactivated influenza vaccines, tri or quadrivalent, 2 A strains, 1 or 2 D strains, grown in chick embryos or cell culture. Older whole virus vaccines not used, side effects. Current inactivated are split product or surface antigen subunit, highly immunogenic, minimal adverse events. Newer virus adjuvanted vaccines stimulate stronger responses, recommended for high-risk groups.
And the live attenuated intranasal option sounds appealing.
Live attenuated intranasal vaccine, trivalent or quadrivalent, Uses temperature-sensitive variant, grows at 25 degrees C, not body temp, 37, 39 degrees C. Recommended for healthy kids 2 years, often more immunogenic than inactivated. But live vaccines avoided in high-risk categories. WHO sometimes recommended only inactivated due to efficacy concerns with live form in certain seasons. Constant evaluation.
Next, rabies vaccine. India, highly endemic, critical public health focus.
Yes, India has 50% global rabies deaths. Tragic. Nerve tissue vaccines not recommended. Poor efficacy, side effects. Modern tissue cell culture vaccines now used. Lyophilized provide 0.25 IU per IM dose. Include purified duck embryo, purified chick embryo cell, human diploid cell, purified vero cell vaccines. Comparable efficacy, relatively safe, lack myelin basic protein.
And post-exposure prophylaxis is a critical emergency response. Very specific protocol.
It is, based on wound category and vaccination history. Category 1, touch, lick, and tack skin, minimal risk. Category 2, minor scratches, abrasions, no bleed, lick broken skin, need vaccine. Category 3, transdermal bites, bleed, mucous membrane contact, need vaccine, A and D, immunoglobulin. All Category 3 need wound management plus vaccine. Category 3 and immunocompromised Category 2 also need rabies immunoglobulin, Shiragi for immediate passive protection. Prior vaccinated people don't need RIG on re-exposure.
Wound care first step, always.
Absolutely paramount. Immediate irrigation, running water 10 minutes, thorough soap water cleaning, apply povidone iodine alcohol, tetanus antibiotics as needed. Avoid immediate suturing, if needed, due after RIG infiltration.
And rabies immunoglobulin, or REG, immediate shield.
Yes, provides immediate passive immunity, neutralizes virus at site, buys time for vaccine immunity, dose per kilogram, body weight, human or equine RIG, infiltrated in around wound ASAP, not day 7, dilute if needed for large wounds, remainder given IN away from vaccine site. Equine RIG, potent, generally safe, but adverse effects common, needs skin test. Human RIG, preferred, but expensive, scarce.
What are the post-exposure vaccination schedules?
WHO schedule, 5 doses, day 0, 3, 7, 14, 28, extra day 90 dose for immunocompromised, updated Thai Red Cross. 2 intradermal doses each, days 0, 3, 7, 30, dose sparing. Abbreviated alternates exist. Zagreb, abbreviated multi-site, reduced 4 dose, 8 site intradermal schedules, re-exposure after prior prophylaxis. 2 booster doses, days 0, 3. Immune system remembers.
And pre-exposure prophylaxis, who gets that?
Offered to high-risk individuals, lab staff, vets, animal handlers, wildlife workers, travelers to endemic areas, etc. Schedule: 3 IM doses, days 0, 7, 21, or 28. Boosters after 1 year, then every 5 years or annually for intradermal schedule. Monitor antibody titers, boost to maintain 0.5 mml.
Next, hepatitis A vaccine. Interesting how hygiene levels affect its impact.
India endemic for Hep A. 50% kids seropositive by 5 years, usually mild. Severity complications higher in adolescents, adults, chronic liver disease patients. 2 types available. Formalin inactivated viral vaccines usually contain adjuvant, single or combo with Hep B. 2 doses, 6-12 months apart, give 95% efficacy if 1-year-old. Maternal antibody interfere earlier. Also live vaccines, H2LA1 strains, single dose immunogenic, safe.
So not a top priority for mass infant vaccination in high endemic areas, but more important as hygiene improves, infection age rises.
Exactly. Not historically top priority, but improving hygiene means later infection age, more risk of severe disease and cholera, fulminant hepatic failure. IAP recommends it for all children if affordable. High-risk categories: chronic liver disease, seronegative travelers, kids in daycare, seronegative adolescents, liver kidney transplant recipients, also effective post-exposure if given within 10 days.
Next, meningococcal vaccine targets serious bacterial meningitis.
Neisseria meningitidis causes 30–40% bacterial meningitis in kids, high fatality. Serogroups A, B, C, Y, WN35 cause invasive disease. India, epidemics usually A, sometimes C, endemic disease mostly B. 2 types. Unconjugated polysaccharide vaccines, teen-dependent, no memory, poor immunogenicity 2 years, bivalent AC and tetravalent ACY-W135 available.
And the better conjugate vaccines.
Conjugate vaccines preferred, higher immunogenicity, prolonged efficacy, potential herd effect, working kids. 2 types in India. Quadrivalent ACY-W135 uses diphtheria toxoid carrier. Monovalent serogroup A uses tetanus toxoid carrier.
Now, yellow fever vaccine, mainly for travelers.
Live attenuated vaccine, 170 strain, effective against all known strains, neutralizing antibodies in 90% by 10 days, 100% by 3 weeks, persists decades, often lifelong immunity after 1 dose, single dose at least 10 days before travel to endemic areas, Africa, South Central America. Revaccinate after 10 years, adverse effects common, avoid in young infants, pregnant women, live vaccine.
Lastly, combination vaccines, the future.
Yeah.
Simpler, more efficient.
Absolutely. Multiple immunogens physically combined in 1 shot. e.g. trivalent polio, pentavalent DTP, distinct from simultaneous administration of separate vaccines. Infant immune system can handle many antigens simultaneously, efficacy usually not altered by concurrent administration.
So, not overwhelming and practical benefits.
Precisely. Needed with 20 antigens required first two. Storage, transport, enhanced coverage.
Challenges in developing them.
Yes. Antigens must be compatible, not interfere, alive vaccines, indicated at same time. Some need adjuvant. Volume can't be excessive. Product must be stable 1 year. Rigorous efficacy cost-benefit analysis needed before licensing. Examples: pentavalent, DTWP, DTaP, DT, DT, OPV, IPV, MMR, MMR, influenza.
With all this vaccination, vaccine safety is paramount. Let's talk adverse events. How are they categorized to assess cause?
Untoward events categorized into 5 types. Crucial framework. First, vaccine-induced, directly caused precipitated by active component. Example, anaphylaxis post-measles, VAPP, BCG adenitis.
Direct biological consequence. What about vaccine potentiated?
Vaccine potentiated, precipitated by vaccination but might have happened anyway. Trigger for underlying condition, e.g. first febrile seizure.
And injection reactions. Less about vaccine, more about process.
Exactly. Event from anxiety pain of injection itself, not vaccine. E.g. syncope, fainting after vaccination. Vasovagal response.
Then events related to administration process errors.
Yes, program error. Event due to error in prep, handling, administration, e.g. toxic shock from contaminated measles, vaccine extremely rare, injection site abscess, human systemic error.
And finally, coincidental events.
Temporally linked by chance or unrelated illness occurring around vaccination time, e.g. gastroenteritis after MMR, not causally related, just happened same time.
Critical to differentiate these for causality. What about minor expected reactions?
Minor reactions common, self-limiting. Fever, irritability, malaise, local pain, swelling, gridness. Settle with cold compress, paracetamol. Strategies to reduce pain, anxiety. Antipyretics, distraction. Breastfeeding sweet liquids, stroking skin near site, rapid IM injection without aspiration, topical analgesia, explaining procedure, sitting position for older kids helps.
What about immediate allergic reactions like anaphylaxis? How common? Known triggers.
Immediate allergic reactions rare, hard to predict. Severe ones, anaphylaxis, usually from vaccine constituents, not contamination. Anaphylaxis extremely rare, 1 per million doses, can follow any vaccination. Yellow fever, MMR, tetanus most implicated. Observe patient 015 min post-vaccination. Differentiate from vasovagal reaction, fainting.
What specific components trigger allergies?
Several. Egg protein, yellow fever, MMR, rabies PCAV, influenza from egg cultures. Gelatin, influenza, MMR, rabies, varicella zoster. Latex, vial stopper syringe, casein, DTaP. Yeast, Saccharomyces cerevisiae, Hep B, HPV. Trace neomycin, preservatives, thiamersyl aluminum phenoxyethanol may cause delayed hypersensitivity. Thiamersyl use minimized due to theoretical mercury concerns. Long safety record.
Are there specific adverse events that must be reported?
Yes, serious ones. Anaphylaxis 7 days. Adverse effects listed as contraindications. Any serious unusual event, any sequelae of reportable events. Crucial for safety monitoring.
And specific documented events linked to particular vaccines?
Yes. OPV, rare VAPP. Measles, rare thrombocytopenic purpura. Infection in immunodeficient. MMR, extremely rare encephalopathy encephalitis. Tetanus, rare brachial neuritis. Pertussis, rare encephalopathy encephalitis. Rotavirus, very rare intussusception. Rubella, rare chronic arthritis. Others. DTP, hypotensive hyporesponsive episode, inconsolable cry. BCG, axillary lymphadenitis. Measles vaccine contamination causing toxic shock is a program error.
And the crucial clarification on MMR and autism. A harmful myth.
Absolutely critical to state. There is no causal relationship between MMR vaccine and autism or inflammatory bowel disease. Extensively researched, definitively debunked by numerous large, high-quality studies globally. Initial flawed or research retracted, author discredited. Public health relies on accurate, evidence-based info. This claim is disproven.
Beyond administration, ensuring potency requires vaccine storage and cold chain management. The logistical backbone.
Maintaining proper temperature is critical. Different sensitivities. Heat sensitive, but okay to freeze. OPV, measles, BCG, post-reconstitution. Less heat sensitive, but damaged by freezing. Hepatitis B, DTP, pentavalent TT, light sensitive. BCG, MMR, measles, rubella, packaged in dark glass.
Specific placement in fridge freezer matters too.
Yes, precise science. Fridge. OPV in freezer, 0 to 94 degrees C. BCG, MMR on top rack's main compartment, 410 degrees C. DTP, DTTT, Hep A, typhoid middle racks, Hep B, varicella, diluents lower racks, warmest. Cold chain system uses specific equipment, walk-in coolers, freezers, ice-lined fridges, vans, cold boxes, carriers, temps monitored constantly.
And the clever vaccine vial monitor, BVM, for field checks.
BVM is crucial for field monitoring. Tag on label cap with heat-sensitive material. Changes color gradually or reversibly with cumulative heat exposure. Usable if inner square lighter than outer circle. Discard if color matches or darker. Time to change varies by vaccine sensitivity. Free G, 2 days OPV, 14 days DTP Hep B combo. Empowers health workers to verify integrity anywhere.
Finally, immunization in special circumstances. Not everyone fits the standard schedule. Tailored approach is needed.
Exactly. Routine immunization for general pop, but high-risk categories need adapted schedules. Chronic diseases, cardiac, pulmonary, renal, liver, etc. Increased infection risk. Should get pneumococcal and activated influenza, varicella, Hep A, rotavaccines, pneumoflu vital for heart-lung disease, Hep A B for liver disease.
What about preterm babies? Different schedule.
Most preterm LBW babies respond adequately. Vaccinate at same chronological age, doses, schedule as full term. Exception. Hep B seroconversion lower if 2 kilograms. Postpone initial dose 1 month if mother HBs ag neg. If mother PASA known, give vaccine plus HBIG within 12 hours of birth. Critical intervention.
In primary or secondary immunodeficiency, critical area, risks, challenges for vaccination.
It is. Immunodeficiency increases risk severity of vaccine-preventable diseases. Recommended. Pneumococcal and activated influenza, safe, protective. Contraindicated live vaccines, BCG, OPV, MMR, varicella, risk of causing disease. Siblings of immunocompromised should ideally get IPV, prevent OPV transmission. Toxoid-killed vaccine safe, but efficacy may be compromised. Check seroconversion titers, may need extra doses.
What about immunosuppressive drugs like high-dose steroids?
Significant immunosuppression, example, prednisolone, or 2 milligrammes a day, or 20 milligrammes a day for 14 days. No live vaccines until 4 weeks after stopping steroids. Live vaccines, okay, if steroids 14 days, low dose, alternate days, inhaled topical interarticular, less systemic effect.
Right.
Preferably complete vaccination before starting chemoimmunosuppressants radiation. No live vaccines for 3 months after such treatment. Inactivated vaccines given during therapy might need repeating.
And specifically for HIV infection, complex balance.
HIV plus kids susceptible to severe recurrent infections. Vaccine efficacy safety depends on immunodeficiency degree. Most vaccines safe effective early infancy. Efficacy declines as disease advances. Live vaccines unsafe in advanced HIV. Symptomatic infants shouldn't get BCG. Neonates of HIV plus mothers indeterminate status start schedule normally. IPV preferred over OPV if feasible. Measles, MMR, varicella given if CD4 15% for age after counseling benefits versus risks.
What about splenectomy or functional splenia? Spleen fights encapsulated bacteria.
Splenectomyasplenia, exam, sickle cell, increased risk of severe infections, pneumo-meningo-Hib. If possible, vaccinate against these 2 weeks before elective splenectomy for adequate response time.
And other miscellaneous special circumstances.
Minor illness, not contraindication, defer immunization during moderate severe sickness, might inhibit response, confuse adverse event assessment. Bleeding defects, give SC instead of IM if possible. Blood products. Avoid live vaccines, except OP yellow fever, for 3 months after blood product admin. Antibodies interfere. Don't give blood products for 2 weeks after live vaccine. Lapsed immunization. Don't repeat entire schedule, just give missed doses.
Finally, passive immunization. Immediate temporary protection when no time for active immunity.
Passive immunity. Resistance from preformed antibodies transferred from another host, e.g., specific antibodies, varicella, Hep B, injected during incubation period to limit viral multiplication. Immediate protection. Normal human immunoglobulin used if specific IG unavailable. Example for Hep A, measles.
Examples of specific hyperimmune globulins used in emergencies.
Several critical ones. Hepatitis A IG, outbreaks, contacts, travelers. Measles IG, immunocompromised infant contacts 6 days post-exposure. Hepatitis B IG, newborns HBsAg plus mothers exposures. Varicella IG, newborns infected mothers, infants 1R, immunocompromised contacts 6 days post-exposure. Rabies IG, bite by rabid animal. Tetanus IG, wound exposure uncompletely immunized, tetanus treatment.
And anti-sera or antitoxins.
Diphtheria antitoxin, susceptible contacts. Anti-tetanus serum, horse, wound exposure uncompletely immunized. Rabies anti-serum, bite potentially rabid animal. Provide immediate critical protection when time is essence and body can't respond fast enough.
Wow. Today we embarked on an incredible deep dive. starting with that intricate dance of innate and adaptive immunity, exploring the challenges of immunodeficiency, and then diving into the profound impact of immunization. From the molecular level complement cascades, T-cell differentiation to global health strategies like eradication and herd immunity, we've truly seen how interconnected and vital these aspects are.
It really does highlight the precision required in modern medicine. From the careful administration of vaccines, the timing, the route, to the sophisticated diagnostics for immune disorders. We've seen the careful balance healthcare systems must strike between national programs and individual needs, or how fundamental factors like cold chain maintenance can literally make or break a public health initiative. This information is truly foundational, offering, hopefully, a mastery of the core concepts.
This deep dive reveals that mastery isn't just about knowing facts, right? It's understanding the intricate relationships and implications. As we've seen, the immune system is dynamic, constantly adapting, and our interventions like vaccines are constantly evolving too. What fascinating new challenges and triumphs might future immunology and vaccine research bring? Not just in fighting infectious diseases, but maybe in entirely new areas like cancer immunity or autoimmune regulation. It leaves us with a powerful thought that understanding these fundamental biological processes isn't just academic. It empowers every individual to make informed health decisions and truly contribute to global well-being.